the differences between primary and specialistic care?
There's a big difference between primary care and secondary care generally. So most patients will come to see the general practitioner before seeing anybody else with any condition. GPs see patients throughout the whole of their lives from birth through to death and establish a long-term relationship with the patient because the care is continuous. But patients come to us with undifferentiated problems, including symptoms that may be suggestive of asthma, but may also be suggestive of other lung diseases. Our job is to try and figure out what is going on and then to manage that disease accordingly. We do that with limited resources and with limited time. In the hospital sector, if we refer a patient to the hospital with asthma, they generally see somebody who's been trained specifically in asthma, who has expert knowledge in asthma, and who has access to other resources such as pheno, skin prick testing, high-resolution CT scanning, and so on and so forth, in order to help to clarify the diagnosis and also to optimize the management plan for the patient.
Which are the steps we need in primary care for patients with asthma?
If a patient comes into primary care and we have confirmed that diagnosis in primary care, including clear confirmation of reversibility of airways, then we need to do two things. We need to get the patient under control, and once we have them under control, using the medications as described in the guidelines, we need to maintain the control of the patient. If we fail to gain control of the patient with asthma in primary care, having made sure that the diagnosis is correct, smoking cessation treatment is given, that the patient has the right inhalation technique, that the patient is taking the medication regularly, that the patient knows what the medication is for, they have a self-management plan and a rescue plan. If all of those things are in position and that we fail to gain control of the patient, we need to refer them to see a specialist to find out what else is going on, because they will not have typical asthma and they may require other treatment.
What is the real-life research?
Real-life research is trying to see what happens when something which is proven to be effective in a randomized controlled trial is used in the community. So, for example, randomized controlled trials answer a question, but the patients in those randomized controlled trials are selected to reduce all the variables as much as possible so the effect of the intervention can be measured. However, only about 4 or 5% of patients are suitable for including in any randomized controlled trial in any therapy area because of all the exclusions. When that medication is licensed or used in the community, things change. The medication is licensed on the back of it, showing the fact that it works, but then you put it into the population and you use it in all the people who were excluded from the trials in the first place. So the question is whether this medication will work in primary care, because it will include the long, the short, the tall, the fat, the smoker, different ethnic groups, different occupations, and so on and so forth. So we're looking at using it in a different population to the population that was used in the trial. Real-life research tells us whether it's still worthwhile using that medication in the community as well as as those that were included in the randomized controlled trial.
What is the real-world effectiveness of leukotriene receptors antagonists for asthma controller therapy?
We know from randomized controlled trials that inhaled corticosteroids are more effective in both achieving better asthma control and reducing exacerbations than leukotriene receptor antagonists. So one of the first real-life studies, a pragmatic trial conducted in the UK by Professor David Price about 10 years ago, demonstrated that whether you use Montelukast, a leukotriene receptor antagonist, either as first-line therapy or as add-on therapy to a inhaled corticosteroid, that the result was as good as guideline-guided care. This is entirely unexpected. It demonstrated it was just as good as an inhaled corticosteroid. So in the real world, for whatever reason, Montelukast demonstrated equal efficacy to inhaled corticosteroids, even though the randomized control trials would suggest this would not be the case.